Let's decide a few things. First of all, most of you shouldn't be the ones here. It should be who? The nurses. Because what you do is you walk out of the room and say, get a urine on the kid. Well, what I'm going to try and do is elevate your asking now for a little better technique. And what we have to recognize some things. Getting a clean urine on adults can be hard sometimes, right? Depending on the anatomy, are they having a menstrual period, yada, 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 you can have trouble getting a clean urine. So let's just understand that it's magnified by 10 when we're talking about kids. Boys and girls are different. Do we have to amplify that remark? And females, young females, will have a urine infection about 40 or 50 times more often than a male. That number holds pretty well throughout the years. So let's just conclude one thing. In a female under 2 years of age who is febrile, who you do not have a source, the test of choice is the urine. It's nothing else. It's not getting blood. It's not looking at their sodium. It's not checking anything else. It's their urine. Because if you're going to hide an infection, it's going to be in the urine. Because everything else you can see. All right, let's just conclude that that is a truism. I mean, we can go through all the proofs on that, but the bottom line is, accept that one. It's pretty good. So looking at the urine, again, excuse me, in febrile females is the most important test you can do. And the various big schools of pediatric infectious disease pretty much agree with that now. You and I have been through, particularly those of us who are old in this room, which are a lot of us, we've been through a lot of schools of thought about febrile kids. How many people here remember greater than 15,000 white count, greater than 102 degrees, they probably had bacteremia? Yeah, that was a bunch of crap. It didn't come out right. See, the question was, could you culture a bacterium? The question was, were they actually going to be sick from that? And the answer was, no, they weren't. The urine is different. An actual infected urine is a good thing to pick up in kids. Because you know what? Treating that is probably a cost-effective thing to do. We can treat it with stuff which is cheap, dirt cheap. Little kids don't need expensive antibiotics, number one. And number two, 3 days worth of therapy is probably all you need. 3 days. Think about that. That's pretty good. 3 days worth of a medicine that costs $5, $6. Might as well do it. All right. Question number one. Are there physical techniques you can use to induce urine? Here's the take-home message from article number 1 in this question. Keep the cup handy, particularly in males. You're going to pull that diaper off of a 3-month-old. What's the kid going to do? Pee. You know what? My kids have been pissing on me for years. And this is exactly what's going to happen. Why is that? Because as you drag that diaper across the end of the penis, or to some extent even in females, what you're going to get is a stimulus. And then they're going to think, the brain says, I'm liberated. Just go. You know, it's the same function that happens when you put little kids in swimming pools. And so they're just going to pee like crazy. Keep the cup available, because if you get a stream at that moment on a male and you can get a couple of cc's, that's all you need. We're going to get into this in just a second. But you don't need a gallon. All you need is a small amount of this stuff, and if they're peeing, if they're free-running fluid, take it. This is good. This article also talks about the fingertip tap technique. You've taken the diaper off now, and if you tap over the bladder, a certain number of people will pick that up as a stimulus. You know, you almost crede the bladder just a little bit. That'll cause them to pee. If that works, terrific. Here's the rule. If you can get free-running fluid without sticking things in there, this is a good thing. sticking things in is secondary to getting free-flowing fluid. That should be the rule in this course. The bottom line, by the way, whenever they compare even washed genitalia bagged to any of these, bagged sucks. Let's conclude one thing here. Everything that we grew up with as kids in medicine doesn't work well. Bagged urines are bad. In fact, in this study, the first study, bagged had about a 51% contamination rate. Particularly in young females, what you're doing is basically getting a wash of the perineum. You're not getting a clean specimen of any kind. Almost not worth your time unless, we'll get back to this in just a minute, there may be some uses, but if you actually culture these people, you can culture a lot of stuff. So think about that. Question 2, can you collect urine from unsoiled diapers? Now, nobody is suggesting that you check the urine in diapers with poo-poo, all right? What about if we take a kid's wet diaper and do that? You know, this is there are 2 interesting studies here. 2 and 3, one's Israeli, one's British. It was very interesting. They took bits of the lining of an unsoiled diaper, males and females. They put it in a 20 cc syringe and they pushed the plunger down and took the drops out. And they only did this obviously in, under 2 years of age sort of thing. And they only had a 6% contamination rate. 6%. So the answer is, if a kid comes in with a wet diaper, wring out the diaper. That's not bad. And here's the key. If you wring out the diaper and the dipstick is negative, you're done. The new urine dipsticks are so good that a negative is a negative. Now, a positive is a little bit of a problem, because then you got to say, well, now I better get something to culture. But a negative is a negative. We like that. This is good stuff. And if the kids just peed on the way in, what are the chances they're going to pee in the next 20 minutes? Not a lot, particularly if they're sick. So the wringing of the diaper is not a bad technique. By the way, how accurate is clean catch? Sex differences are real and huge. Circumcision does make a difference. There are various techniques. By the way, how you take the urine does make a difference. If your nurses are not doing it a certain way, think about it. Little girls should be put on the toilet backwards, because when they did all the studies about labia spread, that was the best labia spread. Again, what we want is no wash of the perineum. We want free-flowing fluid. Put them on backwards. And in this study, it was girls 2 to 10, and that was clearly the best way to collect the urine. 100% of cultures, after you clean them carefully, we've grown up thinking you have to wash people off, right? We have to cleanse them. Well, they looked at the kids. The difference between cleansing and uncleansing on these little girls was 1%. It probably wasn't worth it. See, we think that by washing something off down there, we do a better job. The truth of the matter is, Article 5 is incredibly telling. This is the one on boys. We'll say, well, we'll wash the end of that penis off. What did you actually do? You shoved bacteria into the end of the penis without cleaning. 5% contamination rate. With cleaning, 10% contamination rate. So it's not only didn't it do as good a job, it made it worse. So I think that all this stuff about taking little bits of betadine and stuff like that and rubbing it over the ends of the penis, it's clearly wrong. That does not produce a better, and by the way, if you ask the nursing staff, particularly those who were raised 20 years ago, they're still doing that. and it's not good. It does not produce what we want. All right. What about ultrasound-guided? How many people actually have a little bit of trepidation about sticking a needle over the pubic symphysis into the bladder of a kid? I don't like it. I'm not going to do that anymore. What they say is, in sick kids who have small bladders, you got a 50% chance of not hitting the bladder with that needle. Now, there's some stuff here about use of ultrasound-guided. And I guess if kids are sick, that's a way to go. But you know what? We have a pathway into the bladder. I don't know why anyone would think that catheterizing some child is worse than sticking a needle where you can have hematomas and other complications. I just don't see that technique as valid anymore. You know, did I learn it as a medical student? Yes. Did I think it was barbaric then? Yes. And I think that the data pretty much supports that. Where do bag urines fit in? Let's say somebody did get a bag urine for you. Don't throw it out. Do the dip on it. Because if the dip's negative, what? You're done. Bag urine is okay if it's negative. It's no good if it's positive. It doesn't tell you anything. But you know what? If some nurse did collect a bag urine, I'm not going to waste that urine. Because you buy dipsticks at 4 cents a piece. Stick it in. Look at it at 30 seconds. If it's negative, it's negative. Move on. Don't traumatize the kid any more than that. Here's my view of it. Particularly in young children, where you have no source for the fever, then I think then selective catheterization in high-risk kids is exactly what you want to do. Particularly young females, less than 2 years of age, no source for the fever, they haven't peed in their diaper, there's no free flow of urine, then cath them. I think that's the way to go at this point in time. By the way, what do office pediatricians think about this? Remember the argument we had the other day about standard of care versus standard care? What do the authorities say ought to be done, and what actually happens? Well, it's very interesting. The pediatricians are very, controlling pediatricians is like herding cats. It doesn't work. And they don't necessarily follow what their own organization, the American Academy of Pediatrics, has to say. And in their offices, the difference between bags and caths split right down the middle. It depended on when they trained. And you know what? You're probably not going to change that sort of behavior. By the way, what is the best invasive technique? All of us know about putting in a needle over the pubic symphysis, but I would point this out. Article 13 is the one that you take back and show to people. 4 stars. This is in a program where they compared sticking that needle into the bladder versus catheterization. Catheterization in the hands of experienced nurses was 100%. There was no kid they could not catheterize. Without ultrasound guiding, they only hit the bladder 46% of the time. I think that's and this isn't some, this is a ped center. This is a place where what they do is little kids. So I think that's a very telling argument. Article 14 actually goes along with this. That is, if you're going to catheterize a kid, is topical lidocaine a reasonable thing to do? The answer was, yes, it was. It actually did reduce some of their discomfort. And if you prep them with LET solution or 10% lidocaine jelly or something like that prior to doing it for a few minutes, particularly in young females, you don't have much tissue to go through. You got a very short space there to go through. It actually decreased their wincing, their unhappiness, their crying, all that other sort of, all the levels they use to say, is this kid unhappy? Why not have the nurses do that? See, I know they don't want to, because what? It takes some time. The point is, it doesn't take a lot of time, and you don't have to be anatomically very good. Because if you take a bunch of it, spread the labia and put it on, pretty much you're going to hit it. It's not a bad technique, and there's at least reasonable data here to suggest that the kid is less unhappy. You think if it's your kid, how many people here, if it was their kid, they'd want them to do that? Yeah. See, there's all kinds of things we don't do, which are real simple and cheap and have been shown to work. It's like before you start an IV, go ahead and give them a little local. I do that on all kinds of patients, and the nurses always resist it. They say, well, it's just a little stick. Anybody ever had a 14 put in? It's not a little stick. That thing looks like a saber coming at you. Well, same thing with a catheter. It's not good. Question 6, can the presence of parents reduce the stress of urethral catheterization? I think you have to know the culture. I think there are some cultures who do not want to be in there. And I'm now seeing a few different cultural groups. A lot of Middle Eastern cultures, particularly the fathers, do not want to see their female offspring catheterized. But I'll tell you what I will do. I ask every time. All of these articles, 15, 16, 17, 18, all support the concept of having the parents in the room, or at least asking them, do you want to be in the room? Put them in charge of the event. And most parents, a lot of parents, are perfectly happy to be in that room and comforting their kid. That's the way I want it. By the way, the same studies have been done, you all know this, on CPR. The parents wanted to be in the room. Now, when you're actually starting the line or intubating, maybe that isn't the perfect time to bring them back, but you got to remember, anything that's happening in their brain is worse than what's actually happening in your department. The parents were grateful that they got to be with their kid at the end. All of these parents, 15, 16, 17, 18, all thought that it was a better experience, and they were able to comfort their child better during the experience in the department. So do not send the parents out if they don't want to be going out. By the way, I think that's a universal now. We all grew up with the brown shirt school of nursing, which said, nobody back. You, get out of here. Well, you know what? That's no good. Have a couple extra chairs in the room, invite people back, let them sit there. For the life of me, I can never understand why some 17-year-old girl wants her 19-year-old boyfriend in there for her pelvic exam. I don't know why, but the point is, it's not up to me. It's up to them. If they want it, they feel more comfortable with it, I'm happy with it. See, it's not up to me to make that decision, it's up to them. By the way, question number 7 is one which is, you would think, intuitively obvious. Can visual inspection identify a UTI? We've all walked by the counter and seen a urine sitting there and say, that's infected, right? Looks bad, smells bad, acts bad. If you can't read newsprint through it, all that other sort of stuff. Well, 19 supports you on this. What it says is the sensitivity of picking up an infected urine was 90%. That means if you said, yeah, that's infected, 90% of it was. It doesn't work the other way. If you say, that's clear, there's no infection in there, no. It doesn't work that way. If you say, yeah, that looks infected, I'm going to treat it, okay, and by the way, that's supported. But what you can't do is say, that's a clear urine, or a clean urine, no infection. So visual inspection does have some reasonableness to it. Question 8. How good are dipsticks for kids? I don't want to say this again, but kids are just little people. They're just as good for kids as they are adults. There was some talk about because of certain concentrations of urine and all this other kind of stuff, they wouldn't be as good. Wrong, wrong, wrong. The dipstick for kids is good. And the next 8 articles, 20, 21, 22, they all say the same thing. And it didn't matter, by the way, again, when you're doing kid articles, you can't do what they did in 20. They took kids from 6 months to 16 years of age. You can't mix those groups in most things, right? Because a 16-year-old, you can tell how to put your urine in a cup. You can watch them. You can do this. You can do that. Those are adults you're dealing with pretty much. Now, I know behaviorally and intellectually they're not adults, but anatomically they're adults. You can deal with this. They combine both groups, but it said the same thing. If the dipstick was negative and the micro was negative, you don't have to culture these people. And then they just said, what about if just the dipstick's negative? You're at the 95 to 98% level. You don't even have to do the micro. How many people here only do micro now by protocol if something's positive on the dip? Yeah, that is the way to go. Because if you actually look at the time your techs are doing something, that takes time. You got a kid that looks good, dip negative, you know what? I don't think that's going anyplace. So again, all of these articles say the same thing. The dipstick is in the 95 to 98% range when tested against a cultured urine. Is that good enough? You got to ask yourself that question. Here's my point. If that kid looks sick, okay, then I'll send it down for the culture. But you know what? That's not the majority of what I see. You know, maybe this year, in the last 3 or 4 months, I've had 2 really sick kids. Everybody else is what? Normal, running around, eating popsicles, stealing crap out of the drawers. They're not sick. McCarthy at Yale, 30 years ago or 40 years ago, made a point. He said, sick kids look sick. And that's why he came up with a Yale observation scale and said, if these are the things that you observe, be worried. If you don't see any of those, they ain't sick. I like that. That still means there's a job for me, and it's just not a test you send off. But the urine supports that. Kid looks normal, running around, acting normal. They do not have, and the dipstick is negative, they don't have a urinary tract infection. So I think that's pretty good stuff. By the way, going all the way from 20 to 28, every study there says the same thing. There is no study that challenges this. Nobody's got a study that says, well, here we missed 30%, we missed 20%. Nobody. I like that. This is good. What about the enhanced urine? Here's the mid-zone proposition. You can take your urine down, and an enhanced urine is a spun urine. Most of what we do in the department is on spun, right? The argument was with kids, oh, they got dilute urine, and you'll miss this, you'll miss that. No. You can take it and have them spin it. A spun urine does tend to concentrate stuff at the bottom of that tube. White cells, bacteria, all that kind of stuff. Is it of any value? Well, it is slightly more sensitive, and there is no question about this. If they then take the bottom of that tube and they go down with a pipette, if they have less than 10 white blood cells in the bottom of an enhanced urine, 100% no growth of a pathological organism. 100%. That's pretty good. Because, again, they did it against the enhanced urine against the culture. It just wasn't worth anybody's time to do that. So what it really says is, and this is what I really like, in an enhanced urine, a negative dipstick was 99.7%. If it was negative, nothing would grow out of the culture. 99.7. Now, you've got to remember, that says nothing's going to grow out of the culture. The 0.03% that's left, is that necessarily causing them a problem? No, it's not. How many kids do you actually see who are dying of urine sepsis? Never seen it. Yeah, well, I guess I've seen some kids with congenital abnormalities of their kidneys and things like that, but you know what? That's not what this says. What it says is, if you spun that urine and it's negative, you don't have anything. I like that. Question 10. Is a culture even needed in a child with a negative enhanced urine? And the answer, clearly, 31, no, it's not. Because then they did the other thing of importance. Not only did they culture them, which damn near nothing grew, they went back to those kids where something grew and said, how are they? How were they? They were fine. They'd gotten better. There was no kid in the study missed who went out and was sicker. Not one. I like that. All right, next. Can fever alone, no UTI, produce pyuria? This actually is a very nice study because somebody's always going to say, well, they've got 5 white cells, right? I don't care. 5 white cells seems to be universal. In your spinal taps, okay, in your urine. Doesn't matter where the 5 white cells are. Somebody's going to say, well, maybe they're infected. No, they aren't. 5 white cells never indicated meningitis in anybody's life, and 5 white cells never indicated a urinary tract infection. If you've got an infection, your body's going to respond to it. In this study, what they did, I guess this is 32. What they did was they took those kids with a few white cells. And then, by the way, they went all the way from 12 days of age to 15 years of age. Again, a problem with the study. But these are kids who had no bacteria, but had white cells. How'd they do? None of them had anything. Did they have a few white cells? Yes. But fever alone can produce the suffusion of a few white cells into your urine. No bacteria, negative dipsticks otherwise, you know what? Doesn't mean anything. They were just fine. So fever alone can produce a few white cells. You can't read the micro when it comes back and say 5 white cells or 8 white cells. If there's a negative dipstick and there's no bacteria in that urine, the white cells are not the result of an infection. So don't go chasing white cells, not useful. All right. Last question, do office-based practitioners actually do urine cultures? Are they actually culturing their kids like in the office like we would in the emergency department? And the answer is about 13% of pediatricians culture. How did they decide who to culture? About 13% of the urines done are cultured. How do they decide? If the kid looks sick. Otherwise, they dipstick them and treat them or treat them empirically, but they do not send off cultures. So understand, we're doing it exactly the same way the pediatricians are, the way they've done it for years, and there's nothing the matter with that. So the pediatric people are like us. They do selective urine testing on the youngest, sickest kids, and everybody else, no. No matter what by the way, no matter what their professional society said, that's exactly what they did. All right, any questions about that or comments?